see the echogenicity of the liver, and you also have to see whether there is portal hypertension, the size of the portal vein, free fluid. Always do a slit lamp examination to zoo for KF ring. To identify the etiology, in your mind already you're thinking of Wilson disease. So what are the tests you will do for Wilson disease? You will do the KF ring, you will do the serum celluloplasmin, and you will do the 24-hour urine copper. So if you have this triad, low celluloplasmin, elevated 24-hour urine, you will think of Wilson disease. If you think of hepatitis B, you do the complete HBV panel and you can get a combination of this. The DNA will be high and HBsAg positive. Sometimes you may have to do the autoantibodies, which are the markers for hepatitis AIH. It can be type 1 when ANA and ASMA are positive, but high IgG itself is a clue. High IgG will tell you this is more likely to be autoimmune. Bile acids, this will be the next step for the cholestatic type of thing. These are not included in your liver function test. So you must do, for the etiology, you may have to do bile acids, which are high in all the bile salt transport defect. If you're thinking of tyrosinemia, you will do the urine succinyl acetone. Nowadays, this whole exome sequencing is coming higher up in the panel. So we come to a diagnosis. I'm sure Vibhor, Lalit, Nagendra will all agree. We are doing this little higher when we think of a metabolic liver disease in chronic liver disease. Then we do some tests to find out the complications. This we won't go into it in detail. So for this child, investigation, see this low hemoglobin, count was 80,000, but the TC is normal. So it's not hypersplenism. This low count could be part of the cirrhosis. The bili is hovering between 16.9, 7.9, and then, but you having SGPT more than 5 times upper limit of normal. In a cirrhosis, you don't get this high bili, nor do you get this high SGPT. So you wonder whether there is an acute hit on a liver disease, on the firm liver disease, or is it just that? So this is something little more. Albumin is low, indicating the chronicity. The INR is high, therefore the synthetic function is disturbed. When you look at the test for the etiology, you find the celluloplasmin is low, 8. Any celluloplasmin value less than 10, a single digit number, is a high chance of it being Wilson disease. But why is anti-smooth muscle antibody positive? This is like type 1 AIH. What is happening? Remember, in Wilson disease, 20% of them can have this positive. Anti-HAV is also positive. Does this child have 3 etiology? Possible is this child has Wilson disease. On top of that, recently has developed an acute hepatitis A, and this must be the false positive which can occur in Wilson disease. Let us see a little more. Ferritin showing acute reflex rate reaction. Ammonia is little high. KF ring is negative. KF ring, will it be negative in Wilson disease? Yes, it will be negative in hepatic Wilson. Only 40 to 60% will be positive, whereas in neuro Wilson, more than 90% will be positive. 24-hour urine copper is quite high, 132.58. Nowadays, we don't do deep and challenge, and this cutoff of 40 microgram per 24 hours is taken as a sign, and this is definitely high. Ultrasound course, endoscopy. IgG is also high in this child, 1932, and the ascitic fluid shows cell count, protein 1.2, SAG 1.6. This SAG ratio, serum ascites albumin gradient, the albumin between the serum and the ascitic fluid, anything, the cutoff being 1.1, anything more than 1.1 is indicative of a portal hypertension. So summarizing, as I told you, we have all this, we have this, we have 3 etiologies. So possibility, analyzing the results, there seems to be an acute liver injury because the bili is more than 5. SGPT initially more than 20. That means there is acute hepatitis. However, there are features of cirrhosis also. Ascites cirrhosis, this feature of Wilson disease, acute hepatitis, and you have IgG also increased. So what is the possibility? It's a decompensated chronic liver disease. I think all the PGs will agree with this. It is decompensated. It is chronic liver disease. There is portal hypertension. Is it ACLF, acute on chronic liver disease? What does acute on chronic liver disease mean? That is a hepatic acute insult manifesting as jaundice within 4 weeks in a child who liver. This is a little bit thing, even if you don't say ACLF, but if you say ACLD, it may be good. Or you just say there is an acute hit hepatitis A virus, underlying etiology. Again, we are still in doubt. Is it Wilson or autoimmune? So how will I find out between these two? Because the treatment is going to be very specific for autoimmune, very specific for Wilson. Now, where are we standing? So here we have, this was what I was telling you. What are the complications you expect in your rounds in a child with chronic liver disease? If we ask you, these are the answers you must say. Portal hypertension, resistant ascites, spontaneous bacterial peritonitis, hepatic encephalopathy, hepatorenal syndrome, nutrition, malnutrition, and end-stage liver disease. There are some prognostic scores for chronic liver disease in children. We still use the CTP score, and where these 5 parameters are included. Pediatric end-stage liver disease is used more during transplantation, where again the bilirubin and INR will be common for most of the parameters, indicating that INR is very, very important synthetic function. And bilirubin, it's just look at this. OTPT does not come under any prognostic score. It is only albumin, INR, and bilirubin, which tells you the synthetic function, and the bilirubin is also a functional ability of the hepatocyte to think. So these are very, very important as parameters. So here you come to 2 possibilities, Wilson disease, AIH. And so here you have increased IgG in this child, you have 1 antibody, but you have low ceruloplasmin, 24-hour copper, looks more like Wilson disease. And so a biopsy was done in this child, and you find that these are the copper deposits. Once you get these copper deposits, you get these sort of hepatocytes with glycogenated nuclei. You see these nuclei which are large and which are hyperthing. Then you get this glycogenated nuclei. You see some amount of steatosis. You see fat in the cells distribution. You can see this steatosis. Then you make a diagnosis of copper-associated liver disease. In our country, Wilson disease. So should we do liver biopsy in all? Yes, in pediatrics, we still like for the etiology. But to pick up the fibrosis, we now use the fibroscan, where we look at 2 possibilities. You look at the liver stiffness, and you can say the value. And also there is one test known as the APRI. For exam, we might ask you this. What is the indirect way to say fibrosis? It is the AST platelet ratio index. If it is more than 1, then means the fibrosis is 3. Otherwise, this fibroscan is a good test to tell us that liver stiffness. So here in this child, the gene mutation, I was telling you, now we are doing more of these gene mutations to get the diagnosis easily. And this child was homozygous for the ATP7B gene RN69Q, and therefore a diagnosis of Wilson disease, hepatic phenotype, decompensated liver disease with portal hypertension was made. This is the Lipstick score. You can read it in your book, but we've modified it in the INASIL as for Indian children, where we've used this siblings also give 1 point, and MRI we've done, and we've added 1 more point for this, so that you get mutation analysis. Now the cost is coming down. This is the highest score. If you get 4, that means homozygous, you can diagnose it and establish the diagnosis. So therapy, and I think we won't go into this, but remember, they need decoppering, and Wilson diet is very important. Recently, all my colleagues, we were all having this conference for nearly 1.5 days, and they said, many of them who'd come from abroad said that our Indian diet contains a lot of copper, and we don't understand that it contains, and many of them are continuing to take copper, and that may be one reason where our results may not be very good. So I think this is very, very important to reduce the copper and to continue chelating agent. Still deepen is very good. And now Triantine is available for those who are not able to give. But remember, the cost is little high. We have some scoring. I don't think this is necessary. But if the child is becoming sick, we can do plasmapheresis before as a bridge before transplant. And there are some indications for liver transplant. Autoimmune hepatitis, we can have a scoring, and most important, the interface hepatitis, we have a score for this. So I would just like to conclude saying that it is a chronic liver disease, an important cause of morbidity and mortality. And at this age, more than 5, think of Wilson, autoimmune hepatitis, chronic hepatitis B virus infection. Detailed evaluation and definitive diagnosis should be made. Empirical therapy should not be encouraged. Liver biopsy plays an important role in pediatric hepatology. Plasmapheresis is a very good bridge, especially in Wilson disease. Sibling screening, very important in asymptomatic Wilson disease, and treatment recommended. Immunization with HAV and HB vaccines should be done in all children with CLD. And thank you for your patient listening. Thank you.
Thank you. Thank you so much, madam. Wonderful case discussion along with all the etiologies and everything. We also learn a lot with such type of things when we are when you experts are teaching the PGs, but we also learn many things. Thank you so much, ma'am.
Thank
We can
you.
take some questions if are still I don't see any questions, but if there will be any questions, we will take at the end of the session. So,
Yeah.
madam, one question from my side that you said avoid the use of copper utensils for the water and food storage. So is it that applicable to the general people also or only to the Wilson's
No, no, no. This
perspective?
should, anyone should take only more than 1 part ppm in water content of copper should be there. More than, should not be more than 1 ppm. But there were earlier people were using copper vessels even to store milk, boil, and give the children. And they had specially for the young boys. The girls would not get. They got it in aluminum, and these people got in copper because boys were very important for them. And they were given that milk, and they found this, and a very simple way of just take stainless steel. They found that this ICC came down. So that was a big clue. And so for us, both hits are there. Wilson disease, very, very important. The copper content of water, the copper content of food. Earlier, we thought initially, at least, they have to be very, very, very careful. Once they come to a balance, a maintenance phase, maybe they can be little lenient on their food. But somehow, I think we should be little concerned about the copper associated liver disease because even now there are some clusters in Andhra Pradesh. There's been one cluster reported from Kashmir of ICC, late onset ICC. So it's not good for the liver.
Okay, so because we generally get the gift of copper vessels
Yeah.
sometimes.
That is
So
copper
that's why.
coated mainly for the heat. So this is copper coating of the inner. Oh. Dr. Nagendra Kumar also wants to say something. And I think Lalit also wants to comment on that. Yeah. Yes, Dr. Lalit.
Yeah. So, ma'am, yeah, just a couple of months back, we had a case of ICC.
Ah.
It was a case we saw after, I think, 11 years. And this
Mm.
was a child of 2 years who presented with uh, decompensated liver disease. And the liver was very firm. And after having exhausted the primary workup, when we probed into the history, and there was a strong history of usage of copper utensils for boiling milk. And initially thought that, perhaps this may not be the routine practice, but when we checked with the all family members, they said, no, we have been using copper only. And finally, we couldn't help the child because we started chelation. We even did plasma action, thinking that it might help. But the finally child succumbed, and post-mortem we could do a liver biopsy, which was very classical of ICC. So it
It-
does happen. It is still
Still
present.
happening.
Yeah. So I think the message that Madam gave was that usage of copper utensils for storage of water overnight or for boiling of milk should be discouraged at all age group.
So that classical we used to see in Dr. Nehal, but those will be children less than 3, doctor, like Dr. Lalit said, and we called them malignant liver disease. It was malignant only. It used to run. Maybe transplant would help them. And the study was done whether they have some genetic component which is triggering, but we could not identify at that point of time. Now we feel some of them could have been MDR3 deficiency. Prefix also. We do not know. So I think that time we couldn't do. But remember that it's not good. Dr. Nagendra has also written that to do the liver biopsy, always do the INR and do transjugular. I think it's very, very important. But after doing INR in children, we can do easily intercostal because it's usually enlarged. What do you think, Lalit?
Yeah, I mean, as a pediatric gastroenterologist, I remember we were always taught to do intercostal, and that we have been doing. But
Yeah.
when we get the intervention radiologist to do, they prefer subcostal.
Subcostal, but transjugular may not be necessary.
Yeah, transjugular
Unless
is
it
only
is
yeah.
when it's very small vertical span, which we don't see in children. Transjugular, when we do, Dr. Nehal, is when we want to measure HVPG, we want a biopsy, and we are planning tips. We do everything together.
When the
One more
coagulopathy,
comment.
when the
Hello.
To
coagulopathy doesn't
combine
allow.
all the three. If you want to
Yeah.
measure pressure, if you want the bit, and you do that. Otherwise, as far as possible, we try to avoid, and we get a good bit intercostal. Intercostal, why we like as gastroenterology, we have a good support of the lower rib.
In fact,
Yes,
just
doctor.
Dr.
in
Vikas.
fact, one thing is that if the platelet count is low, so even in that case, you can avoid the transjugular liver biopsy if there's some paper is there. If you start the beta blocker, that can improve the platelet count, and after which you can do the percutaneous biopsy. So we need
All
biopsy,
that.
but transjugular liver biopsy, there is a one paper from the SGPGI where after the beta blocker, 20% of the transjugular liver biopsy could be avoided because of the low platelet. So
Yes.
even you can try a trial of the beta blocker and you can repeat the
See,
platelet.
liver biopsy, doing, not doing, should be the last one. Even now, after so many years, doing a liver biopsy, I'm scared. Do it with caution. And I tell my, don't take it lightly. That one child may be a problem child for you. If it is going to help you in your diagnosis, do it. Otherwise, don't do. Now with our WES, why should we do? Why should we do an invasive procedure unnecessarily? We will not do. That's why I was telling you, Lalita, we put that very much high. Once you get homozygous WES for Wilson, why will I think of AIH?
Yes.
And if you have a prolonged prothrombin time, platelet low, now I don't even have that thing to even try planning it, doing this, doing that, trying to get a biopsy. No, I will not do.
I have one comment to make on.
Yes, Vibhor.
Yeah, this is regarding coagulopathy in a liver disease. So INR may not be the true reflection of coagulation. So basically, it is a disturbed state, means is a altered coagulation, and your procoagulant and anticoagulant factors may be at some other balanced state. So your INR may be prolonged, but actual in vivo still the coagulation may be normal. So at many places, some labs and centers, we are doing thromboelastogram or rotum, and we see actually the functional aspect of the coagulation, that we have to study initiation of coagulation, how is the clot strength and fibrinolysis, how rapidly the clot is fibrin clot is forming. So on that we decide whether the child has a really deranged coagulation or not. If there is a really deranged coagulation, then transcutaneous is risky, then probably transjugular is okay. A little bit borderline biopsy, many interventional radiologists are doing a plug biopsy. So you are sealing the tract so that there is no bleeding. So they can be sealed with the gel phone or can be sealed with the coil also. So these are the options for the deranged coagulopathy.
Yeah, I definitely agree with what Dr. Vibhor said.
only in the conditions where you really need liver biopsy. As madam said, most of the times genetics and scoring systems would help. In that case, either you can, based on the tag, or if you don't have tag, you can even transfuse FFP and see that if INR is near normal, and you can do the biopsy from the intervention radiologist where they can plug the tract. And otherwise transjugular, but generally transjugular liver biopsies are not very good
Good,
biopsy.
definitely.
Won't get the good core also. But
Mm.
if it is very much required, then that is the other option.
So now we have got all the hepatologists giving us. I think this is the thing the PGs should know about TTG. They should know about this plug. At least, when you give another point. So it's very important to all these points which were given by us. Thank you, Nehal. I think you.
Thank you. Thank you so much, ma'am, and thank you all the experts for a wonderful discussion. So with this, we are going ahead with our panel discussion now. The panel discussion, our topic is tiny tummies, big decisions. So acute abdomen in children. For this, we have moderator Dr. Vibhor Borkar sir, who is a pediatric gastroenterologist at Gleneagles Hospital, Mumbai, giving a short introduction to save the time. Our panelists are Dr. Lalit Bharadia sir, who is the consultant pediatric gastroenterologist at Neo Clinic Children Hospital, Jaipur. Dr. Vikas Jain sir, additional professor at and pediatric gastroenterologist at PGI Chandigarh, PGI CH, Noida. Dr. Dhruv Desai sir, pediatric gastroenterologist at Happy Tummy Hospital, Rajkot. And Dr. Nagendra Kumar sir, consultant pediatric gastroenterologist at Rainbow Hospital, Bangalore. I welcome all the experts and the platform is yours, sir.
Yeah. Thank you, ma'am. Are my slides visible?
Yes,
Yes,
yes.
sir. Yes, sir.
Okay,
I
so
welcome
let's.
Baldev sir also. I just seen him in the this. Baldev sir is one of the convener of our Gurukul program. So welcome Baldev sir. He is always there
Doctor
teaching us.
Dr. Asha is also here and Dr. Nandish Bhai is also here.
Yes.
Yeah.
Welcome Ashay bhai and welcome Nandi sir.
Thank you, madam. Best wishes, madam. Best wishes.
Thank you, sir. Yes, sir. It's all yours. Vibhor Borkar, sir.
Yeah, okay. Thank you, ma'am, and welcome everyone to our panel discussion, which is on pediatric, like acute pain in abdomen in children. And we know that the abdominal pain in children is very, very common. Every now and then we get calls from the parents about the pain and all. And many times we see that generally they are very benign and something which can easily manageable, but sometimes there may be some hidden significant pathology. So the today's focus is related to those kind of pain abdomen which we should not be missed. And for that we have our esteemed panel of experts to dissect out the case scenarios. We will basically will be exploring the practical real world approaches which are common but potentially a serious conditions in children. So we will discuss how to arrive to the decision making, how to choose the investigation, and it will be more of a practical base rather than the theory. Okay, so uh, so we know that almost like a 5 to 10% of the visits in emergency are because of abdominal pain. And when child comes, basically the child may be irritable, crying, there is the discomfort, child is not cooperative for the examination. So as a student and also my clinical goal is I had to see whether this is an urgent or non-urgent, and second thing, I am dealing with the surgical or medical cause of this pain. That's how we need to do a triage in when it comes to the emergency. Now age is very important because depending on what age the etiologies can differ. So we as a student we should know, should be knowing, okay, particular age, what will be by the topmost priority. So that table should be in our mind of each student when you are approaching or giving the clinical differential diagnosis for the acute any pain in abdomen. So the sequence of events is very important. That's the art of history taking. So many of the acute pain are associated with the like vomiting. But if generally, if your pain is before the vomiting, generally these are the obstructive and surgical causes. But generally in the medical causes, generally vomiting starts and then there is like nausea, vomiting, and the pain starts. Okay, so the sequence of events are very important. These are not the rule, but this is how the general understanding of the pain. And at the same time, a quick examination is very important. The appearance of the child, if there is a visual pain like a colic and obstruction, the child will be curled up. If there is peritonitis or appendicitis, the patient may be very still and may not like to touch the abdomen. So look for the red flag signs like bilious vomiting, bloody stool, any absence of the bowel movements, and rigidity. So in a emergency, we need to quickly see for the red flag signs, rule out anything emergency. If something surgical is there, then get your surgical colleague into the picture, or we manage medically and evaluate. So do not miss certain things like appendicitis, intussusception, volvulus, any hernia which is getting obstructed, or any ovarian or testicular torsion. Again, very important surgical thing which generally sometimes we miss to examine, and rarely after the trauma there can be a wandering spleen. So this we should not miss. So this of my our today's cases are mainly focused on the medical one and not the surgical one. That is the disclaimer before going to these further cases. So now further let's visit a very common scenario which is very common but a significant one. So this is a 11 years old boy who had a fever of a 1 day mild with upper abdominal pain which is increasing after food, not affected by change in position. So there is a nausea and vomiting for a day, and this was the first time it happened. Hemodynamically, there was a tachycardia, blood pressure was okay, saturation was little bit borderline. There epigastric tenderness, and there was no hepatosplenomegaly, and bowel sounds were absent. There was significant tenderness in the upper part. And if you see the on auscultation, there was a little bit decrease in air entry on the left side. However, there were no creps, and the child was otherwise the restless but coherent. So, Dr. Dhru, in this scenario, what are your possibilities?
Yes, sir. Good evening. Good evening, everyone. So, when I look to the clinical scenario, it's an acute episode, and that acute episode is of a severe type, along with severe epigastric pain. So, first coming to the location of the pain. So, it's an epigastric pain, it's severe, it's of short duration. So, my first would be maybe there is acid peptic ulcer that might give a result like this kind of a pain. Second, obviously, is acute appendicitis that again maybe, sorry, acute pancreatitis that again it's an epigastric location, it's severe, it starts suddenly along with some hemodynamic changes. Yes, of course, there are few hepatic conditions also like severe hepatitis or maybe liver abscess in the left lobe of liver that can present similarly. Uh, there is a desaturation SpO2 of 94, slight hemodynamic instability, tachycardia, fever, maybe septicemia, pneumonia. Yes, but according to the presentation, I would rather go with pancreatitis and then keep all the differentials later on.
Okay, thank you, Dr. Dhru. So it's an upper epigastrium. So for students, we should look for organs like liver, pancreas, stomach, and the lower means the lungs, lower lobes. So that's how you start thinking. Okay, so so with this differential, what investigations will do? So you are seeing this patient in emergency. So what will be your next step?
Sir, first we will do a basic hematological workup that is CBC, CRP, amylase, lipase, a full LFT, create electrolytes, and along with that, some ultrasonographical like USG abdomen to see what is actually going on. Saturation is also borderline, so yes, X-ray, chest, and if CRP is high, then blood culture is also warranted, sir.
Uh, just a minute. Are you able to hear some music?
Music, no.
No, no music.
No, no, no.
No. Yeah.
Okay, I think. Okay, okay, yeah. Sorry, there was some. Just somehow some app is starting in my side. Sorry for the glitch. Okay, yeah. So in this index case, when we did the lab, the hemoglobin was normal, WBC were slightly increased with neutrophilic predominance, CRP was high, and as you suggested, amylase and lipase both were enlarge, sorry, increase, and we have seen the upper limit of the normal range. Otherwise, liver function tests were essentially normal, so there was no hepatitis. There was a little bit albumin was low, and so in this, so what is your interpretation on this, Dr. Dhruv?
Sir, as the amylase lipase are more in the levels in terms of more than 5 times the upper limit, I would like to go in favor of acute pancreatitis rather than anything else. But then I would also like to reconfirm it by doing ultrasound abdomen, so that just that my diagnosis is perfect.
Okay, thank you. So this child, because there was some lung issues, decreased air entry, we ordered X-ray and ultrasound both. So the X-ray showed there was a left pleural effusion, so that correlated with the clinical finding. And ultrasound also confirmed that left pleural effusion without any internal echoes. And there was pancreatic edema, there was some fluid collection. Dr. Vikas, so when you are asking for an ultrasound in a child with pancreatitis or suspected acute one with the upper abdominal pain, so what information are you seeking from a radiologist?
Thank you, Dr. Vibhor. Actually, now we have enough information in the term of the clinical and the biochemical parameters, as these things are pointing toward the pancreatic biliary area. So in ultrasound, we want to know the what is happening in the pancreas. So look for any like edema in the pancreas and surrounding the pancreas, like the collection within the vicinity of the pancreas in the form of the necrotic collections or in the acute fluid collections, or in the other area like in the pleural space. So in the ultrasound, sometimes we get the clue about the pleural effusion and other ascites and other area. And simultaneously, important to know the etiology of the pancreatitis, we have to look for the biliary tract also. Sometimes we have a secondary cause of the pancreatitis in terms of the choledochal tendler pancreas, and some choledocholithiasis. So we need two information. One is the pancreas, surrounding area of the pancreas, and the biliary tract. And uh, sometimes the closer masquerade of the pancreatitis in terms of the, like sometimes the some splenic infarct, some liver abscess, there may be some mild elevation. So other causes we can also rule out simultaneously other than the pancreatitis.
Yeah, thank you, Dr. Vikas. So, compared to adult in the pediatrics, there are biliary causes like an abnormal biliary tract, some stones, or choledochal cyst is again common etiology. So, we should also seek apart from whatever the complication we look for. So, Dr. Vikas, so like what is the diagnostic criteria and how do you further look at this scenario?
So the diagnostic criteria of the acute pancreatitis comprises of the three things. One is the symptoms. Symptom is typically sometimes like in this case the location of the pain in the epigastrium, and sometimes it get relieved by bending forward. And second parameter is like a biochemical parameter where the amylase and lipase usually remain the more than 3 times of the upper limit of the normal. And last criteria is the imaging. Ultrasound in the initial stage is enough to diagnose the pancreatitis in terms of the inflammation of the surrounding edema. There are these criteria is basically the INSPIRE group of criteria where the international study group of the pediatric pancreatitis of in term of the cure. So this is the two criteria. Out of the three criteria, two is met, then we can make the diagnosis of the acute pancreatitis.
And with the clinical scenario, with the other that this child has a little bit air entry issue, fluid collection. So clinically, how will you use this scenario in terms of further management?
So basically, to make the diagnosis of the acute pancreatitis, these three things are necessary enough. But to further categorize into the severity of the pancreatitis, we need two more parameters. One is a fluid collection in the local area of the pancreas, other like in the vicinity of the pancreas, and another thing is a organ failure. So if the child is having the organ failure or fluid collection, we can further categorize the grading of the
Okay.
pancreatitis. We can discuss in the
Okay.
later slides.
Yeah.
So
Okay. So with this child, definitely he has a definitely acute pancreatitis with some other organs other than pancreas is involved. We'll see like how is the we will further categorize this child. Dr. Nagendra, can you just elaborate what exactly happens in pancreatitis, why it behaves so weirdly, and how this pathophysiology is helpful in further management?
Yeah, many thanks for that question, Dr. Vibhor. See, basically, pancreatitis is due to direct activation of pancreatic enzymes. It can be directly by virus or even in obstruction or dysfunction of the pancreatic cellular function, which prematurely activates these enzymes. So, these enzymes are basically amylase, lipase, proteases. So, they basically digest our own cell, which releases massive amounts of free radicals, and it releases lot of prostaglandins, leukotrienes, so which will trigger the whole immune cascade and leads to systemic inflammatory response, and that leads to multi-organ dysfunction. So that is one. And second is these enzymes can leak into the peritoneum and causes lot of peritoneal reaction and peritoneal inflammation. That's why we see there is board like rigidity also in pancreatitis, and even bowel sounds are absent. There are some signs like colon cutoff sign. All these things are secondary to inflammation surrounding the pancreas, and that's another reason why they develop, some of them can develop portal vein thrombosis, splenic vein thrombosis. This is all because of local and systemic inflammation, as pancreas is near to the diaphragm and left lung. So you can see adjacent inflammation of the left pleura also. Even in this case, we have left-sided basal pneumonia with pleural effusion. So it's basically a immune cascade which is leading to all these issues.
Yeah.
Okay.
So it's a significant SIRS response,
Yes.
local, systemic, and some microvascular injuries. So this we need to definitely consider. So how does this injury evolves over the further?
See, first week, generally, Dr. Vibhor, they present with high-grade fever, and most of the times it's not because of sepsis, it is because of the systemic inflammatory response. They can have hypotension, they can go into shock, pulmonary edema, and then collapse or consolidation of the lungs, pleural effusion, and even they can have acute kidney injury or renal failure. So these all complications lead to multi-organ dysfunction, and which will lead to death if not managed properly. Beyond first week, basically it is a complications secondary to the various collections and the subsequent, if we are not managing this multi-organ dysfunction optimally, the complications secondary to that can set in, because these children are very sick and they are taken care in ICUs. There is always chances of nosocomial infections, and in fact infection into these necrosis of the pancreas and systemic infection is a major killer in the second week, and multi-organ dysfunction secondary to systemic inflammatory response is a major killer, major reason for death in children with acute pancreatitis in the first week of illness.
Yeah, I think very important points. We will connect so these two slides of pathophysiology and how the further injury progress. to the various aspects of management and complications. So please remember these slides. Lalit sir, how do we grade this pancreatitis severity?
Yeah, so before I dwell upon this, I'll a quick quiet point about the diagnosis of acute pancreatitis. What we have been commonly seeing when we get a patient referred as acute pancreatitis, they have just marginally elevated amylase lipase, and they have some mild pain, and ultrasound is normal, but just because of mildly elevated amylase lipase, they are being treated as acute pancreatitis, wherein they are not acute pancreatitis. This is my experience many a times because they have some gastritis. Any part of the GI tract can have slightly elevated amylase lipase. So it is very important we follow the cutoff of 3 times upper limit of normal for it to be of pancreatic origin. Also, along with that, either the clinical symptom should be very characteristic or a sonology picture should be there. So, 2 out of these 3 should be there. Otherwise, we get referral for acute pancreatitis and they are not acute pancreatitis. So, coming to this slide, so severity of grading is very important. By and large, most of the acute pancreatitis will need hospitalization, and most of the severe acute pancreatitis will need an ICU hospitalization. And another addition to the previous slide where Nagendra said, if not managed properly, severe acute pancreatitis, we may lose them. But I would like to say that despite best of the management, severe acute pancreatitis can still be fatal in almost 15 to 20% of the patient. So the pancreatitis can be graded. Either there are clinical scores. Now, Vibhor has enumerated this. So D-Banto score is more of a, it is only for the exam, not relevant clinically. Japanese is a score which takes into account CT scan also. So it is not very popular in children because we don't really want CT scan to be a part of each and every scoring system. Apache and Renaissance are fairly good score where they have different 12 and 13 parameters which take into account, and based on that how many of them are present. They are basically more of them heart rate, respiratory rate, saturation, PaO2, hematocrit, creatinine, LDH, all these parameters they take into account, and then we are able to give them a score and then predict either diagnose severity. So Apache more than 8 will be able to show that this is severe acute pancreatitis, less than 8 is not severe. Ranson's takes into account scoring at baseline and at 48 hours. And then that will help you to give in terms of mortality and probability of complications. Now, these all scoring system are not very useful in pediatric because they are not standardized for pediatric. What is more important for pediatric is the NASPGHAN guidelines and this revised Atlanta classification. They're more or less same. Revised Atlanta classification are more relevant for the adult and the NASPGHAN are for pediatric, where they take into account the severity of graded into mild, moderate and severe. Very simple clinically, if there is no tachycardia and no tachypnea, this is by and large a mild pancreatitis. For moderate, definitely they will have definite tachycardia and tachypnea. Apart from that, there will be local rigidity guarding, maybe distension, paralytic ileus. These are the clinical things. And then if there is an organ failure, this is defined in the next slide. If this organ failure is transient, wherein many of them, they will have hypotension, they will have hypoxia at admission, but you then give them treatment, first aid, they improve, and then they come out of this severe criteria. So they are moderate severity where the organ failure improves within 48 hours. And in some, the organ failure will persist at 48 hours. They are severe acute pancreatitis. And what is organ failure defined as? A systolic blood pressure less than 5th centile, pulmonary PaO2 less than 60, renal failure where the creatinine is more than 2 despite rehydration, or a GI blood loss of 500 ml per 24 hour. The correlate for this is the drop in hematocrit on subsequent monitoring. And if there is a radiological sign of local fluid collection, if we definitely do a CT scan when there is severe acute pancreatitis, again, that is to be done preferably after 72 hours. If that shows necrosis, these are all automatically qualify for severe pancreatitis because none of the mild pancreatitis will have these changes. So this helps you to prognosticate the families that this is the falls into the moderate category or severe category, and based on that, they have to be prepared for a very long struggle in ICU and also mortality in significant proportion.
So, thank you, sir, for a very crisp description of this grading. Suppose child comes and in the emergency, I got a mileage of 5,000. Does it mean severe pancreatitis?
Yeah, so then another very important point before you mentioned is that you've seen people chasing amylase, monitoring amylase, and so is monitoring transaminase for hepatitis. So it is very important to know that amylase is only for diagnosis of pancreatitis. It is not for prognosis, not to grade severity, not to judge when to start feed, because the earlier school of thought was that when the amylase come down to normal, that's the time to start feeding. So again, that should not be a practice. Amylase is required only at the time of uh, initial diagnosis, and when there is recurrence, of course, or when there is a complication, you may do monitoring of amylase. Otherwise, doesn't indicate any severity of
Yeah,
pancreatitis.
yeah. Thank you, sir. That was point I want to stress so that not to chase the amylase level. If you see all the scoring, the other scorings also that are not much relevant, none of the scoring actually uses amylase and lipase levels. Okay. Now, Dr. Vikas, like how do you manage? A patient is there in the ER with the severe pancreatitis. How should I manage?
So, before going into the detail of the management, first I would like to emphasize this is a condition where the role of the antibiotic is in the very bottom in the management and only in the selected cases. So, these management start with the hydration. So, if we go back to the pathophysiology during the acute episode, there's a lot of necrosis, lot of inflammations that leads to the derangement of the microcirculation in the pancreas. So early fluid resuscitation is a hardcore management in the pancreatitis. So management of the pancreatitis should start with the aggressive fluid resuscitations during the early 72 hour, and it should be started within the first 24 hour within the present 24 hour within the presentations. So like in the fluid resuscitation, three things we have to answer. One is when to start, which fluid and how much. So it should be started immediately to prevent the further cascade of the event. We have to start the fluid resuscitation within the first 24 hour or immediately after the presentation of the child within the emergency. And fluid, there's a lot of debate regarding the use of the fluid. Obviously, the crystalloid is a fluid of choice. Among the crystalloid, lot of literature are available in the adult that show the ringer lactate is a better fluid, but now the data is coming in children also that show the ringer lactate is more efficacious than the normal saline in decreasing the SIRS response and the progression of mild pancreatitis or severe pancreatitis. So definitely the ringer lactate is a fluid of choice, and only in the some selected cases the colloid has a role, but definitely in the early stage crystalloid within first 24 hours, and fluid should be 1.5 to 2 times of the maintenance fluid. And if a child is in the hypotension, then the 1 or 2 bolus of the 10 to 20 ml per kg bolus can be given in the first before maintenance fluid. And another criteria is that around 1.5 2 to 3 ml per kg per hour of the fluid can be given in the first 24 hours. But most importantly, rather than just going blindly about the fluid, we have to monitor the patient for a child for a overload conditions. So it's like a dynamic effort. and we have to titrate the fluid in the first 72 hours in terms of the like pulmonary edema, in hepatomegaly, if there is a coarse crepitations. So if there's a, these are the marker of the overload. And on the other hand, if the child is having the drop in the heart rate and falling of PP in a normal range, or decrease in the BUN, or improvement in the urine output. Urine output is one of the most important clinical parameter that we can use in monitoring the fluid resuscitation. So definitely in the early phase, fluid resuscitation has a major role in the management. And next is the after the fluid resuscitation, the child is obviously the main wincing with the pain.
Yeah.
So,
So I think
so the next
analgesia we can skip details
okay.
of
So I
analgesia because
I
time
would
is
like to
limited.
just end
So the
just briefly.
yeah.
I would just like to just mention a few points regarding the analgesia. In a mild to mild cases only we can manage the most of the pain with the like only the paracetamol is important. And in the later part of the step ladder, then acetaminophen or NSAID, then we can give the tramadol and other drugs. But morphine, if not needed, should be avoided because it can precipitate the condition. So most of the pain we can manage by the paracetamol and the NSAID.
Okay. So the fluid is very important. We give more fluids first 24 hours, but later on we have to decrease the fluid to avoid pulmonary edema. So that should be kept in the mind. Now, Dr. Dhruv, let me know like when CT scan should be done and what is the role of the CT scan? Be very specific and to the point.
Yes, sir. There are three ways the CT scan can be very useful in acute pancreatitis. First is when there is diagnostic dilemma, when the blood parameters or the sonography is not convenient, not conveying the proper diagnosis, and the clinically you feel that it is acute pancreatitis, then CT scan can be done at the earlier phase of time, but usually avoided. And CECT, contrast enhanced CT, is the one we should do. But as we have already known, there can be renal dysfunction along with this acute pancreatitis. So if the creatinine is normal, CECT can be done later on to see what is the current condition of the pancreas, whether there is any necrosis, whether any peripancreatic collections or not. It can also give an idea about the CBD, the stones, or any calcific thing in the pancreas. And also, you can stage the pancreatitis according to the grading so that we can know the prognosis of the child. Okay, we can explain the parents how and what are the prognosticating factors. So, usually we have the grading system, which is known as the CT grading system of Balthazar and CT severity index score, where we grade according to grade A, B, C, D, E, according to the appearance of the pancreas and according to the surrounding irregularities or inflammation, or if there is any single fluid collection or more fluid collection. And then again, in presence of necrosis, whether it's absent, it's up to 33%, 33 to 50%, or if it's more than 50%. And when we combine all the scores, we get a CT severity score. If it's 0 to 6, then the percentage of death is around 3.8%. And if it's 7 to 10, then it drastically increases to 18%. So this helps us for the prognostication of the patient and for counseling the parents.
Yeah, excellent. So generally CT we do after maybe 48 to 72 hours because before that many a times the necrosis of the necrotic features on the CT do not appear. So we may underestimate the severity if we do earlier. So we can do it on after 48 hours minimum. Nagendra, can you quickly tell us about the present role of nutrition and the what we called as the nutritional rest?
Yeah, Dr. Vibhor. So basically, I think there is quite wide practices when it comes to nutritional diet prescription in children with acute pancreatitis. Again, I would emphasize that grading of the pancreatitis becomes very important. Milder pancreatitis, we can resume nutrition as soon as oral nutrition as soon as possible. So basically, timing should be as soon as possible, and as soon as you see if there is a bowl, sounds are there, and there is no need for unnecessary to keep NPO nil orally for long term. I have seen even 72 to 3 to 4 days people have kept a nil orally even in mild acute pancreatitis. And when it comes to severe pancreatitis, okay, parenteral nutrition versus central nutrition, I think we should always focus on enteral nutrition whenever and wherever it is possible. And the only criteria what I generally follow is if there is no ileus or if there are bowel sounds, then start orally. So if child is tolerating, then gradually increase the feeds and go to maximum whatever you can support. And next question is what feeds you need to select. So you can start with clear liquids, but quickly you can go for low fat soft diet because that will be very comfortable for the child. Basically, why we are choosing low fat diet is to give pancreatic rest. Again, lipase is absolutely essential for digesting fats, while simple carbs and regular fluids and electrolytes does not need much of pancreas. So we will start with low fat soft diet, and normal formula should be enough. And if child is not taking orally and if the pancreatitis is too much, and then you can go with nasogastric tube. And only if there is associated pancreatic ascites where ducts are leaking, then nasojejunal may be required, not in all cases of acute pancreatitis. And always when you are putting nasogastric tube or nasojejunal tube, can go with polymeric formulas. They are comparable and easy and less uh, costly. I mean, they are more cost effective. So go with regular polymeric formula is what is recommended, and this is what we are doing. And it's a dynamic thing. Every day you need to see his child is able to tolerate this and then upscale the diet. But most important is no need for unnecessary keeping nil orally for long time.
Yes, true. And another important, as you explained, the pathophysiology. So
Yeah.
if we give the gut unnecessary undue rest, your enterocytes will not get adequate nutrition. So your intestinal barrier will become leaky, and chances of trans migration of bacteria product to the systemic circulation, thus getting infection, and again this bacteria going into this collected fluid is high. So early fluid decreases your morbidity, and early enteral feeding decreases the morbidity. Lalit sir, quickly, can you tell us about antibiotics, pancreatic enzymes in acute pancreatitis, and when do you call a surgeon?
Right. So, a role of antibiotic, there is very, very clear statement that there is no role of prophylactic antibiotic in any pancreatitis. What we have commonly seen is that acute pancreatitis of mild variety receiving very high-end antibiotic. This practice should not be, should not be agreed upon. So, only indication of antibiotic is perhaps worsening clinical condition in the second week of uh, uh, illness, or when there are clear-cut evidence of sepsis in the form of either a culture positive sepsis or a CT scan showing presence of air bubble or gas in the pancreas, which suggest an anaerobic infection, or whether there is any extra pancreatic sepsis, focus of sepsis, then definitely they should be given antibiotic. Important to know the choice of antibiotic. Now, if you look at the pancreatic penetration, the best penetration is carbapenem, so that is meropenem. Second best penetration is piperacillin tazobactam, and the third best penetration is quinolone. So how I use it, that when there is mild infection, need for an antibiotic, quinolones are good. Those with moderate pancreatitis, we can go for piperacillin tazobactam. Those with severe acute pancreatitis, we go for carbapenem. Regarding the role of uh, pancreatic enzyme, there is no role of pancreatic enzymes in acute pancreatitis. So there is no role of using enzyme preparation. Role of surgical consultation, again, this is something in a private practice, definitely for all severe acute pancreatitis, I would prefer to have a surgical consult. Having said that, surgeon would be very, very skeptical to do anything in the first week. At the most, if there is a pressure on them, because if the child is worsening and there is a reason to believe that there is some infection in the pancreatic necrosis, either in the form of rising CRP, rising PCT, that a surgeon or an intervention radiologist may have to do an FNA of the necros area, prove there is sepsis, and then look for some way of drainage. Otherwise, surgery in severe acute pancreatitis in first week carries very, very high mortality.
Yeah. Yes. So thank you. So this was basically, we have just had a quick overview about how to approach these cases, utility of amylase lipase imaging, early treatment is with aggressive IV hydration, analgesia, monitoring, and early enteral nutrition. Again, antibiotics are not required in mild, moderate pancreatitis. In very severe, where you're doing some invasive things, then as a prophylactic, maybe like central line in or ventilation, otherwise, no. So quickly, we can go to the second case. Uh, he's an 8 months old girl, and here she had for last 2 days she has high grade fever. She had excessive irritability, insoluble cry. Parents were not able to understand what's going on, and she had vomiting with decreased intake. She was now feeling a little bit lethargic, and now her urine has turned yellow, and were few stools were pale, few stools were normal. There was no other significant history. So, if this patient comes to us, Dr. Dhruv, what do you think? How will you assess this child?
Sir, first of all, it's an infant. Irritability, high-grade fever definitely can mean septicemia or severe sepsis with poor feeding and lethargy, again indicating to the same. But when they say dark yellow urine and pale stool, that means that there is some kind of biliary flow that is being affected, maybe cholestasis or maybe some pathology which is related to the CBD or even the liver. So, depending upon the investigation, we can further go ahead and describe how or can reach to a diagnosis of the patient, sir.
Yeah, so basically it's a fever and some pale stool irritability. So I'm thinking you are thinking about something liver involvement, biliary involvement. So at this age, what do you think can be the etiology?
Particularly, it's a short history, not a long history. Sudden onset of everything. So maybe some kind of a block into the biliary tree, maybe a choledochal cyst obstructing, or maybe a stone which is there, which is obstructing the tree, and then resulting into a biliary cholestasis and biliary hepatitis. So that could be one possibility along with the sepsis. And on the investigation, obviously, it shows that the CRP is very high. Obviously, sepsis is there. There is conjugated hyperbilirubinemia. There is hepatitis. Albumin is normal. So that means that it's not a chronic process, something that is acute that has resulted into this scenario. And INR is also deranged. So that means that the liver function has been impaired, and this child may also have some kind of liver failure.
Okay. So we started this child on antibiotic. So do you think so piperacillin and tazobactam. So then what next you will do with this child?
Sir, preferably an ultrasonography to see
Okay.
the structure and to see the further imaging to diagnose the case.
Okay, so we did ultrasound, Dr. Nagender.
Yeah.
So this child ultrasound shows CBD of 13 mm, and there was intrahepatic biliary radical dilatation and some query calculus. So what is the interpretation and how what should we see here?
Yeah, I mean, there are two things. One is choledochal cyst, and second is just a normal duct where duct is blocking. So now the CBD measures almost 18 millimeter, which is quite huge. And with the 13 mm calculus, which is probably obstructing the lower end of CBD. And also, there is a surrounding inflammation leading to cholangitis. So definitely, this looks like choledochal cyst with impacted calculus and associated cholangitis, and yeah, and there is a lot of sludge also seen in gallbladder.
Okay, so the sonologist has suggested to do MRCP. What will you do?
Yeah, definitely MRCP is very useful to see exact anatomy of the and even classify choledochal cyst. So right now child is in sepsis and child is very sick. First we need to stabilize the child, and second is when we are thinking about intervention, that is the time when MRCP will be much more useful. We know already there is I mean CBD is obstructed, there is sepsis,
Yeah,
cholangitis. So MRCP might be considered when we are planning any
yeah.
procedure once child is stable.
Yeah, so what is that it right now it's not required, and
Yeah,
sometimes the finer details of ducts can be missed, like PB junction anomalies and all these things might be missed in an acute stage. So
yeah,
generally we do it in a later stage. So
yeah.
Dr. Vikas, so how will you manage this child? What approach should we have?
As Dr. Nagendra already mentioned, this is the case of the suspected choledochal cyst with cholangitis. So if you just see the investigation, this child will fall in a moderately severe classification of the acute severe cholangitis as per the Tokyo classification. And we have already studied the broad spectrum antibiotic in this patient. So we have to titrate the response within the next 48 hours in this patient. We have a two option. One, we have to continue the patient on the broad spectrum antibiotic fluid resuscitation, and that's to see whether the child is improving or not within the next 48 hours. If there's an improvement, then we can decide the elective surgery later on. But if child doesn't improve within the 48 hour, then we have to act upon it, and we have to just put the PTBD. We have to drain the underlying collection, so to have a response. So this is a tricky situation. Within the 48 hour we have to assess the response to keep the patient on the antibiotic, and reassess after 48 hour for the drainage of the biliary tract.
Yeah, so one question is like in this patient in the chart, so why we choose the piperacillin tazobactam in this child?
Because the gram negative, actually the most common infection in this kind of the patient is basically the gram negative, and penetration of a antibiotic piperacillin tazobactam is quite good. So the selection of the antibiotic is a
Yeah.
good in this case because of the gram negative
Yeah.
broad gram negative coverage.
Yeah, so that's the thing. Basically, knowing the disease is important. So it's the not only the antibiotic, means the bug for which we choose the antibiotic. It is also the system. The way in pancreatic we chose the antibiotic which has a good penetration in the pancreatic bed for a biliary system compared to other beta lactams. Piperacillin has a better penetration. So that's the reason. So now this child, as Dr. Vikas has suggested, we use all the means of conservative management. And from 9th Feb to 12th Feb, when we repeated the labs, the clinically tachycardia was there. The fever continued. There is irritability. Child had decreased intake, lethargic. However, there was no hypotension. We repeated the labs. The CBC has gone up to the 40,000. CRP has gone up to 284. This Billy has gone up. Albumin is little bit decreasing. So, Lalit sir, this situation, what should we should do in this situation?
Now, definitely our conservative management, despite our conservative management, the cholangitis has worsened. So certainly this child needs urgent biliary drainage. Now the question is at 8 months, what are the options available to us? Had it been a child more than 4 years, 5 years, it would have been a straight away an ERCP, which will be both diagnostic as well as therapeutic, and you do biliary drainage and the child dramatically improves in next 48 hours, and then he can be subjected later to the definitive surgery once the cholangiogram confirms that this is uh, choledochal cyst. However, at 8 months, this option is not available. Now, for surgeon to straight away open in such a high bilirubin is also a very high risk situation in an acute sepsis going for a full blown laparotomy. So, what comes the second option is a percutaneous transhepatic biliary drainage, abbreviated as PTBD, which is done by intervention radiologist. And in a dilated intrahepatic bile duct, it becomes quite easy for an expert intervention radiologist to do that. Again, if the facility of MRCP is available in the same hospital, if the child is not very sick, it is advisable to have an MRCP before doing any intervention. But sometimes this may not be possible. So, with a good ultrasound and with an expert intervention radiologist, he may be able to do the life-saving drainage even without MRCP, without the MRI. So, this child undergoes
So,
PTBD.
yes, sir, please continue.
Yeah, so this child, intervention radiologist will locate the dilated intrahepatic bile duct, pass a guide wire across it, and this guide wire is then passed distally, deep down into the CBD and then into the duodenum, and then over this, a drain is put. Initially, the drain is put so that you decompress the biliary drainage. Later on, the drain can be internalized, and then when a contrast is injected into this, a cholangiogram is also obtained, which will give you the definite diagnosis whether it is just choledochal cyst, which type of choledochal cyst, or whether there is an associated lower end CBD anatomical reason which leading to secondary bile duct obstruction and dilatation. Hello?
Am I audible? Yeah, some
Yeah,
network
yeah,
issues from my side. Sorry.
yeah.
Please continue, sir.
Yeah, so this child underwent an emergency PTBD, and we can go on the next slide, I think. Meanwhile, there were some questions on the chat. Meanwhile, can we take that?
Yeah. So this child. Yeah. So this was the second case. I think we can go ahead with the questions. Third case might take more time.
Yeah.
So is it okay, ma'am?
Yes, yes, sir, completely. So,
Okay.
uh,
And
almost the question was answered. Like Baldev Prajapati sir asked for the rationality of choice for piperacillin tazobacter, and Vibhor sir has said that we needed an antibiotic with the good biliary tree penetration. Another question is how to monitor clinical course of pancreatitis, CRP or procalcitonin or both?
any of the panelists?
Yeah, I think in an intensive care, I mean, we generally take entire things into account. So it is not only either CRP or PCT, preferably both. And along with that, the the clinical scoring, sometimes they have a role in this because, like let's say Apache, they are one-time score and then serial Apache score will help you to really, assess whether he is worsening clinically. If there is rise in just the septic parameters, then definitely, and also there is correlation, increase in the inotrope or increase in the oxygenation requirement, then it is considered as a sign of sepsis, and then the calls for an antibiotic upgrade, or if he is not on antibiotic, to start an antibiotic. I think the entire situation everything is taken into account to decide whether there is a sepsis which has set in or whether the sepsis has increased.
Okay. Any other students or attendees, if you have any doubts regarding these two wonderful cases which were shared?
One more comment. Basically, both CRP and procalcitonin in the first week of severe acute pancreatitis are not the indicators of sepsis. So just because CRP is high, or even procalcitonin for that matter, we should not simply put them on multiple antibiotics. So that is very important. Yeah.
Yeah, so as Baldev sir also commented that the clinical course can be best monitored clinically. Yeah. So uh, thank you so much for two wonderful case discussion with the panel pancreatitis and the cholecyst. Uh, I okay.
Chronic liver
So
disease. And one.
yeah, Baldev sir's another comment that CRP and procalcitonin may not be useful. So it was the same thing Nagendra sir told us. Best to judge clinically, definitely. So thank you so much for today's wonderful discussion. Malthi madam started with the like a opening female batswoman, I should say, and then the team India won with all the panelists. Thank you so much, Vibhor Borkar sir, for wonderful two case discussions, and all the panelists, Lalit Baradia sir, Nagendra Kumar sir, Dhruv sir, for taking us through the journey of the acute pain and the tummy when hurts. So thank you so much, sir.
Thank you very
All
much, ma'am.
the
Thank you very
yeah,
much.
Baldev sir also, he is always there to teach us, to guide us, and he always shares the platform to learn also. Digant Shastri sir is still here, Nandish bhai is still here. So these all things are so motivating. Thank you so
Thank
much.
you.
Yeah,
Thank you.
thank you,
Thank you, Dr.
everyone.
Neha.
Thank
Thank
you.
everyone.
Yeah, I should
Thank
take
you. Thank
Thank
Yogesh
you,
you.
sir.
to restart
You
Take
all,
it.
care.
you all
Thank
look
you,
very
everyone.
bright to
Thank you.
continue.
Thank you.
Good night, sir. Good night.
Good
Sir,
night.
Thank
next
you.
week
Good
also
night.
the same, the GIT panel is there.
Oh,
Dr. Nishant Wadhwa is moderating.
okay.
Yeah, and
Thanks.
Yeah.
Thank you.
Thank you.
Thank you.
for PG students, you are going to have one quiz and with the exciting prizes of the quiz on GI. So what we learned in all the four this week, we will
Sessions.
have one quiz with the participation. So please, all of you, please participate. Thank you. Thank you
Thank
so
you.
much.
Nandish bhai
Thank you
also,
so
you can
much.
also join.
Good night.
Thank you.
Thank you.
Good night. Good night,
Definitely,
everyone.
Good
definitely,
night.
sir.
Yeah.
Good
Yeah.
night.
Definitely.
Good
Good.
night.
Good.
Good
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 night.
night,
night.
Good
Vibhor
Good
night.
sir.
night,
Good
Good
Vibhor.
night.
Good night, Lalit. Good night.
Yeah.
Good
Good
night,
Nagendra,
night.
good
ma'am.
night.
Good
Good
night.
night. Good
Ma'am.
night.
Good night,
Vikas, good
Good
everyone.
night.
night,
Good
Dhruv,
night.
night,
Nagender,
sir.
Dhruv,
Good
good
night.
Lalit
Good
night.
night,
sir.
Yogesh sir. Good
Thank
night.
you.
Good night,
Very
Malti
nice.
madam. Good night,
Very
Yogesh sir.
nice.
Good night,
Thank
Yogesh
you.
sir, Malti
Yeah,
ma'am.
good night.
Yeah.
Good night. And thank you for moderating the session with the very
Thank
short
you, sir.
notice.
Thank you, sir.
Thank you,
So
madam. Malti madam.
I
Thank you.
should thank panelists for a T20 match. They didn't have any clue what I'm showing.
So I told you, na, you all of
Yes,
you
the
can do
video will be
one.
available on YouTube. Yes.
Yeah, yeah. It will be available
Okay.
tomorrow.